Disclaimer: I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. Anatomy receptor. The development of the bony and membranous labyrinths of the receptor in the auditory system is described with the development of the vestibular system in Chapter 12. Figure 12-1 outlines the basic components of the inner ear. Figure 15-1 shows the three basic components of the ear. The cochlea is the coiled portion of the bony labyrinth in the petrosal portion of the temporal bone that contains perilymph. The degree of coiling varies with the species of animal. In the dog cochlea, 3.5 turns are present compared with the 2.5 turns in the human cochlea. The portion of the bone that forms the center, or axis, of the coiled cochlea is the medulus. It contains the cochlear division of the vestibulocochlear nerve. At the base of the medulus, the cochlea is continuous with the vestibule, and an opening into the tympanic cavity is called the cochlear window. A shelf of bone projects into the cochlea from the medulus. This is the spiral lamina, which partially divides the cochlea into two portions and is absent at the apex, or most distal extent of the cochlea. Figure 15-2. The cochlear duct is the coiled portion of the membranous labyrinth derived from the embryonic ectodermal otocyst. It is located inside the cochlea and contains endolymph. It is a tubular structure, which, in transverse section, is triangular in shape. The apex of the triangle attaches medially to the spiral lamina, and the base of the triangle attaches laterally to the outer wall of the cochlea. See figure 15-2. This completes the partitioning of the cochlea into two portions, each filled with a continuous column of perilymph. The two sections are the scala vestibuli and the scala tympani. The scala vestibuli is situated dorsal to the cochlear duct. It communicates proximally with the vestibule and distally at the apex of the cochlear duct, with the scala tympani. The latter occurs because the cochlear duct does not reach the apex of the cochlea, leaving an opening between the two scalae that is known as the helicotrema. The scala tympani is situated ventral to the cochlear duct. It communicates distally, at the helicotrema, with the scala vestibuli. Proximally, at the base of the coiled cochlea, the scala tympani terminates at the cochlear window, which is covered by a membrane that retains the perilymph within the bony labyrinth. On the other side of this membrane, at the cochlear window, is the air-filled tympanic cavity of the middle ear. This cavity is bounded by the petrosal bone dorsally and the tympanic bulla ventrally. Perilymph fills the scala vestibuli and scala tympani. See figure 15-1. A small perilymphatic duct connects the scala tympani with the subarachnoid space medial to the petrosal portion of the temporal bone via the cochlear canaliculus. At the level of the origin of the cochlea from the vestibule, the cochlear duct communicates with the saccule by way of the ductus reuniens. Figures 15-3 through 15-5 show the microscopic features of this anatomy. The base of the triangular cochlear duct, when viewed in transverse section, is attached to the outer wall of the bony cochlea and consists of a stria vascularis and a spiral prominens. See figures 15-2 and 15-5. A thin layer of tissue called the vestibular membrane forms the dorsal border of the cochlear duct. This membrane is between the perilymph of the scala vestibuli and the endolymph of the cochlear duct. It extends from the stria vascularis dorsolaterally to the spiral lamina medially. The basilar membrane extends between the spiral lamina and the ventrolateral extent of the stria vascularis at the middle of the lateral wall of the cochlea. Figure 15-6. See also figure 15-5. The basilar membrane is a highly organized layer of collagen fibers. The spiral organ of Corti, is the specialized sensory neuroepithelium that is located on this basilar membrane. This spiral organ is composed of hair cells and several types of supporting cells. The hair cells have, on their luminal surfaces, modified microvilli known as stereocilia. The tips of these stereocilia are embedded in a proteinaceous membrane, the tectorial membrane, which covers the hair cells and is attached medially along the apex of the cochlear duct. The hair cells are associated with various types of supporting cells located on the basilar membrane. The dendritic zones of the neurons in the cochlear portion of the eighth cranial nerve are in synaptic relationship with the bases of the hair cells. Sound waves are transmitted from the air medium of the external ear canal to the solid medium of the tympanum in the chain of 3 ear ossicles, which extends to the vestibular window, and to the fluid medium of the lymph in the scala vestibuli. Wave flow through the perilymph in the scala vestibuli is reflected to the basilar membrane by way of the vestibular membrane and the endolymph of the cochlear duct, or by continuing through the helicotrema to the perilymph in the scala tympani. Movement of the highly organized basilar membrane causes the hair cells of the overlying spiral organ to move and their stereocilia, embedded in the tectorial membrane, to bend. This action causes an impulse to be generated in the cochlear neurons. The basilar membrane acts as a resonator, and deferent portions respond maximally to sound waves of specific frequencies. This function may be related to the length of the basilar membrane, which is longest at the base of the cochlear coil and progressively shortens through the coils to the apex. High frequencies affect the basal portion of the basilar membrane maximally. Low frequencies cause maximal vibration of the basilar membrane at the apex of the cochlear duct. In dogs, the basilar membrane is sensitive to a frequency range of 2 to 47 Hz, compared with a range of 1 to 19 Hz in humans. Cranial nerve 8, vestibulocochlear nerve. Cochlear division. The neurons of the vestibulocochlear nerve are derived from plaque ectoderm associated with the otocyst. The dendritic zone of the cochlear division of the eighth cranial nerve is in synaptic relationship with the base of the hair cells in the spiral organ. The axons course medially along the basilar membrane into the medulus. The cell bodies of these bipolar neurons are located in the medulus at the origin of the spiral lamina, where they form the spiral ganglion. The axons course through the center, or axis, of the medulus to the internal acoustic meatus, where they are joined by the vestibular division of the eighth cranial nerve. Within the vestibulocochlear nerve, the axons of the cochlear division course to the region of the cerebellum nullary angle at the junction of the medulla and the pons, caudal to the transverse fibers of the pons. They terminate in telodendria on cell bodies in the dorsal and ventral cochlear nuclei that are located on the side of the medulla where the nerve enters. These nuclei bulge from the lateral side of the rostral medulla where they appear to be in the vestibulocochlear nerve. See plates 11 and 12 in Chapter 2. Brainstem nuclei and tracts. The axons of the cell bodies in the cochlear nuclei pass into the medulla by one of two pathways. 1. Ventrally through the trapezoid body, or 2. Dorsally over the caudal cerebellar peduncle by way of the acoustic stria. See figures 2-10 and 2-11, and plates 11 and 12 in Chapter 2. Numerous pathways involving a number of synapses are available in the brainstem to the auditory system for reflex activity and conscious perception of sound. Figure 15-7. Reflexes are mediated directly through the influence of cochlear nuclei neurons on the lower motor neurons, LMNs, in brainstem nuclei, or they are mediated indirectly by transmission through the neurons of the caudal colliculus or other neurons in the brainstem. Reflex regulation of the sound wave frequency occurs by way of the afferent neurons of the cochlear division of the eighth cranial nerve, the cochlear nuclei, and the efferent neurons of the motor nucleus of the trigeminal nerve in the pons that innervate the tensor tympani muscle, and the efferent neurons in the facial nucleus in the middle of the that innervate the stapedius muscle. These muscles control the degree of mobility of the ear ossicles. Other neurons that belong to the auditory system and function in both reflex and conscious perception pathways include the dorsal and ventral nuclei of the trapezoid body, the nucleus of the lateral lemniscus, and the caudal colliculus. The neuronal cell bodies of the ventral nucleus of the trapezoid body are scattered without specific arrangement throughout the axons of the trapezoid body. The dorsal nucleus of the trapezoid body forms a distinctly encapsulated nucleus ventrally in the rostral medulla, dorsal to the trapezoid body and dorsolateral to the pyramid. From the level of the facial nucleus in the middle to the motor nucleus of the trigeminal nerve in the pons. See plate 11 in chapter 2. The lateral lemniscus is composed mostly of ascending axons in the auditory system as they course from the rostral medulla through the pons to the caudal mesencephalon on the lateral surface of the brainstem. See plates 9 and 10 in chapter 2. The lateral lemniscus contains axons from the cochlear nuclei or the various nuclei of the trapezoid body on the same side or the opposite side. The lateral lemniscus is formed medial to the middle cerebellar peduncle and is exposed on the lateral surface of the caudal mesencephalon rostral to the transverse fibers of the pons that form the middle cerebellar peduncle. Embedded along the ventromedial aspect of this lateral lemniscus is the nucleus of the lateral lemniscus. The lateral lemniscus terminates at the caudal colliculus. The caudal colliculus consists of cell bodies of neurons and axonal processes organized in laminae. See plate 9 in chapter 2. It functions as a reflex center for the auditory system. Efferent axons projects two elements in the brainstem by way of the tectonically pathway and two elements in the cervical spinal cord through the tectospinal pathway in the ventral funiculus. The latter arises from the rostral colliculus. Efferent axons projects to the thalamus in the brachium of the caudal colliculus located on the lateral side of the mesencephalon ventral to the rostral colliculus. See plates 8 and 9 in chapter 2. They terminate in the medial geniculate nucleus. See plates 7 and 8 in chapter 2. Thalamocortical pathway axons in the conscious projection pathway arise primarily from cell bodies in the caudal colliculus that project rostrally in the brachium of the caudal colliculus. This brachium is located on the lateral side of the mesencephalon and courses rostrally to the medial geniculate nucleus of the metathalamus. This nucleus protrudes from the quadrilateral aspect of the thalamus and extends caudally beside the mesencephalon. See plates 7 and 8 in chapter 2. The caudal colliculus and medial geniculate nucleus are readily seen on magnetic resonance imaging (MRI). The medial geniculate nucleus is the specific metathalamic projection nucleus for the auditory system, and it projects axons by way of the internal capsule to the neocortex of the temporal lobe. This auditory system cortex is located primarily in the sylvian and ectosylvian gyri. Studies in the dog have localized the auditory conscious projection pathway to the ectosylvian gyrus, where the various frequencies may be arranged from rostral, high frequencies, to caudal, low frequencies. This rostrally projecting auditory pathway is characterized by diffuseness and a bilateral distribution. Despite this, at the cortical level, a contralateral representation of each cochlear duct is predominant. Thus, impulses stimulated in one cochlear duct are conducted predominantly to the opposite temporal lobe. The crossing occurs at the level of the trapezoid body, between the nuclei of the lateral lemniscus, and at the commissure of the caudal colliculus. Deafness by recording brainstem auditory evoked potentials. Researchers have found that some evidence of perception of sound exists at 10 to 11 days of age in puppies. In normal dogs, it may take as long as 2 weeks for the external acoustic meatus to open completely. Audiometry studies first detect sound perception at 5 days of age in kittens and 14 days in puppies. Normal hearing of environmental sounds in dogs usually develops by 4 to 5 weeks of age. For that reason, as well as the practicality in handling puppies at this age, it is best to delay electrophysiologic tests for hearing until at least 6 to 8 weeks of age. Partial bilateral loss of hearing and complete unilateral loss of hearing are difficult to establish on the clinical physical examination of domestic animals. Owners may be able to appreciate some degree of hearing loss when their pet is in its normal environment. Complete bilateral deafness usually is caused by direct or indirect interference with the function of the receptor organ. For central lesions to produce deafness, extensive damage must have occurred to both cerebral hemispheres or to the conscious projection pathways on both sides of the brainstem. Such a lesion would most likely produce severe neurologic signs referable to the interference with other systems adjacent to the auditory pathways. Because of the multitude of brainstem pathways available for the auditory system, a large margin of safety exists for this function. Therefore, when you are presented with a deaf animal, your attention should be directed to diseases that affect the receptor portion of this system rather than a brainstem abnormality. The best clinical test for total deafness is to challenge the sleeping patient with a loud noise. Owners will often report that their pet does not respond to the call lighting of cooking pans or ringing of the doorbell. When creating noise, be careful to not create vibrations of the floor which will wake the animal. Inability to arouse the patient in this manner is the best evidence of total inability to hear. Less obvious degrees of deafness are difficult for you to appreciate clinically, and careful observation by the owner of the patient in its own environment may be the most reliable means of determining any degree of deafness. Sophisticated procedures have been developed to determine hearing in animals, including the technique of monitoring changes in respiration in response to hearing sounds as well as recording responses to auditory stimuli on electroencephalography. Far-field potential from brainstem responses to auditory stimuli may be recorded percutaneously from the brains of animals. The various waveforms far-field potentials that are observed have been related to specific components of the peripheral and central portions of the auditory system. The most common procedure used by practicing neurologists is the recording of brainstem auditory evoked responses. This technique may be used to determine an auditory defect and to specify the level of the interference with this system between the peripheral receptor and the thalamus. The procedure may be performed in an awake, sedated, or anesthetized patient. It consists of a specialized ear plug that provides the source of an auditory stimulus, most commonly in the form of clicks. The evoked responses are recorded through subcutaneous electrodes inserted over the calf area. With each click, a recording is made. The recordings from multiple clicks, often 1,000 or more, are averaged together to create a final tracing. The evoked responses consist of 4 to 6 waves seen within 10 milliseconds of the delivery of the clicks. The first wave is generated by the vestibulocochlear nerve. The origin of waves 2 through 5 is less precise. Wave 2 is thought to be from the cochlear nuclei. Wave 3 from the dorsal nucleus of the trapezoid body. Wave 4 from the lateral lemniscus and its nucleus. Wave 5 from the caudal colliculus. And wave 6 from the medial geniculate nucleus. Normal animals have 4 to 6 recognizable waveforms. Animals that are deaf because of lesions that involve the receptor organ or nerve show a flat line with no waveforms. Patients with brainstem lesions may show a delay in the appearance of waveforms 2 through 6. Despite this, MRI remains a more sensitive and specific manner to assess the brainstem. This procedure is most valuable in determining unilateral deafness in puppies that are being tested for the inherited forms of receptor organ deafness. It is also useful in determining brain death in patients being maintained on life support systems. Impedance audiometry, including tympanometry, have been used to evaluate the integrity of the conduction components of hearing in the external and middle ears. Two forms of deafness are related to the peripheral components of the auditory pathway. 1. Conduction deafness and 2. Sensory neural deafness. Conduction deafness. Conduction deafness results from any obstruction to the passage of sound waves and mechanical energy created in the ossicles from the external environment to the spiral organ. Obstacles include the air pathway in the external acoustic meatus, the tympanum and bony pathway of the ossicles through the middle ear, and the fluid medium of the paralymph in the cochlea. The receptor is still functional in response to vibrations induced in the petrosal part of the temporal bone with a tuning fork or bone stimulator device, but not to sound waves that are prevented from reaching the receptor organ. Using a tuning fork in animals is unreliable. Alternatively, a bone stimulator may be used to record brainstem auditory evoked responses. Congenital absence of an external acoustic meatus is rare. We have diagnosed this in a group of closely bred German Shepherd dogs being used as working dogs in a specific colony. Acquired causes of conduction deafness include inflammatory lesions, which are common in the external acoustic meatus and in the tympanic cavity of the middle ear. Neoplasms may also involve these structures either directly or indirectly and prevent the passage of sound waves. Tumors of the external and middle ear, for example, may prevent sound waves from reaching the cochlea. Additionally, tumors of the trigeminal nerve in both dogs and cats may result in denervation of the tensor veli-palatini muscle. This denervation and resulting atrophy of this muscle will alter the normal function of the pharyngeal orifice of the auditory tube. A number of these patients develop a fusion in the tympanic cavity and presumably a unilateral conduction deafness. The cause of the deafness that is associated with aging, presbycusis, is poorly understood except that it most likely results from dysfunction of the peripheral components of the auditory pathway. It may involve arthrosis of the articulations between ear ossicles that prevents their movement, conduction deafness, or a late form of abiotrophy of the hair cells in the spiral organ. Sensory neural deafness. Sensory neural deafness. Sensory neural deafness involves an abnormality in the receptor organ or in the neurons of the cochlear division of the vestibulocochlear nerve. The two forms of sensory neural deafness are the congenital and acquired forms. Congenital inherited sensory neural deafness. Congenital inherited sensory neural deafness is a common disorder, especially in dogs. Numerous breeds are affected. Electrophysiologic testing has determined that hearing is usually present in affected dogs in the first few weeks of life but is absent by about 60 days of age. This supports a degenerative pathogenesis, rather than hypoplasia or aplasia. This form of deafness involves the function of the cochlear duct. Two pathogenetic mechanisms have been described using terminology that seems confusing to us. One is related to albinism and involves dysfunction of the stria vascularis, cochlear saccular. The other involves abiotrophy of the hair cells, neuropithelial. We prefer the use of the terms albinotic and abiotrophic for these two forms of congenital sensory neural deafness. Albinotic form. Albinotic inherited congenital sensory neural deafness is associated with dysfunction of the stria vascularis because of the lack of melanocytes at this location. Here, albinotic refers specifically to the stria vascularis and not the animal's coat color. Affected animals do not necessarily have an albinotic coat color. The production of endolymph and the maintenance of its normal endocochlear potential is a function of the stria vascularis. See figure 15-6. The latter involves the transfer of potassium ions into the endolymph. In the absence of melanocytes in the stria vascularis, this function is inhibited. The abnormal endocochlear potential leads to degeneration of the hair cells of the spiral organ and hence to deafness. Thus, this form of deafness occurs in animals that are partially or completely albinotic. The deafness may be unilateral or bilateral. White-coated, blue-eyed cats are notorious for this form of deafness. The incidence is nearly 50%. Dalmatians have a 30% incidence of the albinotic form of deafness, which is inherited as an autosomal dominant gene. Deafness has been recognized in at least 12 different breeds of white-coated cats, in numerous breeds of dogs with predominantly white or merle coat colors, and in white mink. Abiotrophic form. Abiotrophic inherited congenital sensory neural deafness directly affects the hair cells of the spiral organ. The endocochlear potential is normal in these animals. The lesion is usually bilateral and occasionally also affects the hair cells of the vestibular system receptors. The inheritance usually involves an autosomal recessive gene, although most of these abiotrophies cause deafness at a few weeks of age. Occasionally the onset of deafness occurs later in life. In the Cavalier King Charles Spaniel, deafness may not be apparent until 3 or 4 years of age. Our understanding of the pathogenesis of congenital deafness is markedly compromised by the difficulty in processing the inner ear after death to obtain histologic sections as free from artifacts as possible. Moreover, no antemortem test that differentiates these two forms is available because of the difficulty of rapid preservation of the structures in the membranous labyrinth of the inner ear after death and the need to decalcify the petrosal portion of the temporal bone to obtain these sections. Although a list of 69 dog breeds with congenital deafness has been published, in most cases, it is not known whether they have the albinotic form or the abiotrophic form of deafness or some other pathogenesis such as a hypoplasia or aplasia. Acquired sensory neural deafness. Acquired sensory neural deafness occurs most commonly secondary to infections that cause inflammation of the middle ear and extend into the structures of the inner ear. The clinical signs of dysfunction of the peripheral components of the vestibular system predominate, and deafness is not recognized clinically unless a lesion is bilateral. See case example 12-9. Temporal bone neoplasia is a less common cause of unilateral deafness. Be aware that the small perilymphatic duct provides a direct connection between the cerebrospinal fluid in the subarachnoid space and the paralymph in the scala tympani of the bony labyrinth. Meningitis and otitis interna may occur concomitantly more often than we appreciate. As a rule, the clinical signs of meningitis mask the clinical signs of otitis interna. A less common cause of acquired deafness is ototoxicity. The list of drugs and chemicals that are potentially ototoxic is very long. You should be especially concerned with long-term administration of the aminoglycoside antibiotics. Many ear cleaning agents are ototoxic if they gain access to the middle ear through a ruptured tympanum. Some of the chemotherapeutic agents used in the treatment of neoplasms may be ototoxic, and you must be aware of their published toxic effects. The specific effects of these drugs and chemicals vary according to the dose used, the duration of administration, and the species in which it is used. Some affect the receptors of the auditory system, others affect the vestibular system receptors, or both may be affected. However, it should be noted that it is sometimes very difficult to separate an underlying otitis interna, with associated clinical signs, from an ototoxicity caused by the medication used for the treatment of otitis externa. After all, many of these medications assumed to cause ototoxicity are being used in diseased ears. Age-related deafness is common, especially in older dogs, and is referred to as presbycusis. The causes of this form of deafness are not well understood. Some cases may involve conduction deafness caused by arthrosis of the ear ossicles and their consequent immobility. Other cases may be age-related degeneration of the hair cells in the spiral organ. Be aware that this form of deafness may not be recognized by by the owner until the dog receives general anesthesia for some minor procedure such as dentistry or ear cleaning. What role the anesthesia has in precipitating the sudden observation of deafness is not known. Presumably, the patient had already lost most of its hearing before the anesthesia, but this had not been appreciated by the owner or the veterinarian. Hearing aids for dogs have been utilized by some clinicians. However, they have little utility in veterinary medicine. From our perspective, the patients do not tolerate the apparatus well and eventually shake it from the ear. On occasion, the patient has consumed the fairly expensive equipment. That said, if an owner wants to explore this option, cooperation with a human medical group is recommended.